Okay, so thank you very much for joining us in this new session of the IHE Experience sessions. This is a best practice sessions with two cases, one from in the Greek context and one in the Dutch context. So let me introduce a little bit the first half hour related to the Greek eHealth Interoperability Framework and the different work that is being now done in Greece. We have the pleasure of having with us Dr. Ioannis Kotsiopoulos, who is acting as the Secretary General of Health Service. So he is an executive at the Ministry of Health, and he's managing all the digital transformation of the ministry in collaboration with the Ministry of the Digital Governance that has been established here in Greece as well. So so that we have enough time to make the presentation and maybe sometimes for questions, I'll give the floor to Mr. Kotsiopoulos to start presenting a little bit the Greek case. So, Ioannis, the floor is yours.
Thank you, Alex. Thank you to the panel for the invitation today. It's a great honor to be among so many knowledgeable people in the IHE. I know that the community has moved things forward over the last few years, and at the heart of our strategy is interoperability. So we're very keen to work with other member states and IHE, of course, to see what are the best practices, how we can move things forward. And at the heart of our health system is digital transformation. I'll present a few slides today to show you the challenges that we face here in Greece and how we believe and why we believe that digital transformation is key for providing better and safer services to our citizens. So let's move to the first slide. Okay, I'll start from the challenges of the Greek national healthcare system just to kind of prove the case that really we cannot move forward without using the digital tools. There are four main challenges that are very similar to most of the member states. So what we're facing is huge funding gaps. We have an aging population, which means that most of the people here in Greece live longer, and at the last few years of their life, they have a lot of chronic diseases that create a lot of burden to the national health system. So we have to face that challenge. We face a huge shortage of healthcare professionals. And of course, on top of all that, we have to deal with the pandemic. So let's go to the next slide. Just to give you an indication of where we are in terms of total funding for the healthcare system, as you probably know, Greece has faced a lot of financial difficulties over the last 10 years. So the total funding for the Greek health system was 9.6% of the GDP in 2010. And according to official statistics, that percentage has now been down to 7.7% in 2018. And I don't think it has changed that much over the last couple of years. So in terms of public spending, it's more or less the same. Where we were below the Southern Europe, which is the red line, and a lot lower than the EU average, which is about 7.9% of the GDP. So in Greece, we spend about 4.5%, which might have gone up to 5% according to the official statistics, but it's still a lot less than the rest of Europe. So we're facing funding gaps, which means that we have to be able to offer better services at a lower cost. And this is where digitization really can offer solutions. Let's move to the next slide. This is a slide that shows the red line is the index of the aging population. And you can clearly see that that has gone up dramatically over the last 10, 15 years. So we really face an older population. We have to provide better services to elderly citizens, which is much more difficult than providing healthcare services to a younger population. It means also that the population of Greece has now started to shrink, which means that we have less young people to look after and more older people to look after. And that's going to create a big pressure to our healthcare system. Let's move to the next slide. I talked before about the shortage of healthcare professionals. I know that most EU countries are facing similar issues. Just to give you an idea of where we are in Greece, we employ about 3.3 nurses per 1,000 population, where in Norway, they employ 17.7. And of course, the EU average is about 8.8. Which means that in Greece, we really have to find ways to offer safer services with less people working at the healthcare sector, and make sure that the services we provide are safe. And that's a huge challenge. And one has to think about on how we develop digital technologies to be able to work in an environment that there is a huge shortage of healthcare professionals. Let's move to the next slide. Now, everyone over the last 2 years almost has been facing this huge struggle with COVID-19. Every healthcare system in the world has been struggling to deal with the pressure that COVID-19 is creating to the healthcare system. We've seen a very long period where all the activity has practically stopped in order to be able for the country to cope with the pressure on the healthcare system. Greece has coped relatively well. This is the percentage showing the mortality in 2020. And Greece, compared to the other countries in this chart, has done quite well, despite the fact that the Greek healthcare system was underfunded and was failing in a lot of ways. Despite of all that, there was a huge effort from all the healthcare professionals in Greece. We made a huge effort to make sure that everybody had the right equipment, was ready. We hired about 10,000 additional members of staff for the Greek healthcare system, which is more than 10-15% of the whole workforce. So a lot of things happened within the last year and a half, in order to be able to make the healthcare system to be ready to face COVID-19. And I think the results so far show that we have done a good job. Let's move to the next slide. So clearly what we want to do is we want to find ways to offer the ideal patient care. I've borrowed that slide because the end goal is not digital transformation. Digital transformation is just a tool for us to provide better patient care. So there are lots of ways that you can do that. You can use other methods of continuous improvement, lean management, and all of these techniques to make sure that every day you're trying to be better. Every day you're trying to offer a better service. And of course, in order to do that, you have to take into account the organizational structures where you're working. And you have to take into account the culture of the organization that you're working with. And this is something that a lot of people don't really take into account when we're talking about digital transformation. And digital transformation will always fail when we don't do that, when we don't talk to the healthcare professionals, the people working at the front line. And to be honest with you, over the last 10-15 years that I've been working on digital transformation projects, what I have concluded is that people always come first. You have to deal with the whole project as a change management process and not as a technology change process. So let's move to the next slide. So is digital transformation a hype for Greece or a game changer? And my argument here is that it can become a game changer, because what we really want to do is to eliminate the inequalities in access to the healthcare services. And Greece is just another country where people do struggle to find good access to healthcare services. They struggle because of the queues in the hospitals. They struggle with the emergency departments. They struggle to find an appointment with their GP. So all of these issues related to access to health services can be dealt with if we try to use the digital transformation to provide new services closer to where the patient lives. So that's why I have had this picture of an elderly person using a healthcare services from home. This is where we want to get to. Alex, let's go to the next one. And the other thing is that now we have the opportunity really to create a new digital experience for our citizens. And there are now new ways of having access to our own data and making sure that using technology, we can manage our own health. And of course, I've just copied an example of an app where the patient can really look at them all and then figure out on whether this person needs to visit a GP or a consultant, and whether there's a good probability of these mole being benign or not. So the patient really gets into control of his own health, and this is what we want to do. Let's not forget, though, that when we talk about digital transformation, the goal of our program is to make sure that we provide reliable tools for the healthcare professionals to work with. A lot of the times, the tools that we provide are difficult to use, and healthcare professionals are getting frustrated. And the people that are spending their lives every day working with our patients need to be enabled to do their job better. And using the tools and the technologies that are available right now, we can improve the quality of the healthcare services. And this is a clear example, for example, of how you can use AI to predict breast cancer. And this is much safer for the patient, and it's a really good tool for the healthcare professional to use. So let's move to the next slide. So the last challenge that we'll have is we want to create an environment at the hospital level which is safer for the patients, and going digital is really about patient safety. If we have all the data about the patient in one place, they can be looked at by the clinician. The patients can really have a good conversation about their own health, and this is where it is critical to be able to get all the information together and use the technology to inform clinical decision making. So this is what we want to do, more or less, these kind of four pillars. So we have created, let's go to this slide. Yes, thank you. We have created and submitted a program at the Recovery and the Resilience Fund, which has been approved today. Actually, it's the day where officially the program has been approved by the European Commission, that really deals with all these kind of ambitions and challenges that I have described before. So the first pillar is the National Digital Patient Health Record that collects all the data, and it will be available both to the clinicians and the patient. The second sub-program is the Cancer Treatment Digital Transformation, which is really important for us because we really want to digitize all the processes around our cancer patients. The third one is how we can improve our hospital environment and how we can prepare all the hospitals in Greece to be ready for this digital transformation, and how we can actually provide the tools for the clinicians to be able to use them at a hospital level. The fourth one is really important for Greece, is telemedicine, because we have a lot of remote areas in Greece that have very limited access to good healthcare services. And the fifth pillar is a horizontal pillar, which has to do with how AOP, which is the insurance fund in Greece, can actually digitally process all the invoices and move to kind of the next level and deal with all kind of the reimbursement of all the providers in a digital way. So it's a huge program. It's I think it will be it can be the game changer for Greece. It's almost 350 million euros for the next 4 or 5 years. I think that the duration is rather short for such an ambitious program, but we are optimistic that we can actually achieve that. So next slide. So the Greek So Greek healthcare digital transformation funding program is based on the implementation of robust, well-defined and well-governed eHealth interoperability that Alex is going to talk to you about. The alignment to all the EU standards and the common vision, because we have actually adopted a lot of the ideas from other member states. We have been talking to Spain, Ireland, the UK, to get ideas of how we can actually achieve this program in a shorter period of time. And of course, we know that this is just the start of the digital transformation. We do accept that it's going to take a longer period of time for all these things to happen, but and it will require additional reforms within the organization. But this is, I believe this is the start to start changing things. And of course, we don't want to reinvent the wheel. We want to get the lessons learned from other European countries and obviously focus on the best practices. So let's move to the next one. Of course, there are political and legal issues that we have to take into account. I believe that we do have a broad consensus from the political world, and we can actually mobilize all the experienced health professionals here in Greece. We want to create the digital leaders within the health world. And we know that if we really want to offer a sustainable change program, we'll have to make sure that all these changes are kind of described in a legal document. It has to be, we have to create some legal reforms, let's say, that will enable the whole program to take place. So let's move to the next one. Right, time management. I think the challenge of the whole program is it has, as I said before, it has to be completed within the next 5 years. And obviously we do know with this is going to be challenging, not only due to the fact that you have to think of the organizational changes that are linked with this program, but you also have to think that there are lengthy procurement processes because we're talking about a huge amount of money. So if we're talking about international tenders, these tenders tend to take a lot of time, and then implementation takes time as well. And as I said before, it's not just about technology, it's about how quickly you can actually change the organizations to be able to adopt all these changes. And that's I think the biggest challenge. The second thing that I had in mind when I was designing this program with my colleagues is how can we make sure that this program is sustainable, and when things on the political scene is changing, the program will continue and it will continue to be successful. So this is still something that we need to develop. So that's why we're thinking of a continuous governance scheme that's not just by filled in just by politicians, but it's also kind of linked with the people that will have the people working at the hospital level that will take ownership of this program, and they'll make sure that it will deliver within these 5 years. So let's move to the next slide, because I think I'm talking a lot today and time is running out. Okay, so this is about, again, about the user experience. A lot of the times, I am myself a technology person, so we tend to design things in silos, and then we do wonder why clinicians don't end up adopting the solutions that we designed. And I've given a mandate to everyone working with me at the Ministry of Health is to make sure that every level we work with the people working at the hospitals to make sure we do understand their needs and design solutions that will actually change the way healthcare services are offered in Greece. If we do really want to redesign how healthcare is delivered in Greece, we'll have to work with the healthcare professionals. Technology people don't really understand in that much depth on what clinicians, nurses, and everybody else at the hospital level really need. So that's why one of the big things of the program is the development of digital leaders. Let's move to the next slide. This is just kind of to say that we've been looking very, very closely at the European priorities, which are very similar to what we're facing here in Greece. Perhaps we face bigger challenges in terms of funding, in terms of movement of healthcare professionals. As you probably know, a lot of, or might have heard, a lot of Greek doctors have now moved to other member states because of the financial crisis. So really have to think of how we work together with the rest of the member states to understand these challenges and work and create an environment where one member state helps the other to resolve these issues. So digitization, I believe, at a European level needs to be coordinated. So yeah, okay, let's move to the last slide, I believe. So we'll have a lot of opportunities, and the funds from the European Recovery and Resilience Fund are coming at the right time, where we need to restart the design of the Greek healthcare system. And in order to do that, digitization and digital transformation are at the heart of the redesign of the healthcare services. But it's not the end goal. The end goal is how can we offer better and safer services to the Greek citizens. And having said that, I have to say that I'm really proud of my team here at the Ministry of Health. Alex is also included, because we've been working for a long period of time to make sure that we submit a successful proposal to the European Recovery and Resilience Fund. And I think now is the time where we can really start changing things here in Greece. Thank you very much.
So thank you, Ioannis, for presenting the Greek case. So in the remaining 10 minutes, I'll try to move and describe the interoperability framework, which is maybe more common to the audience, so we can maybe move a little bit faster. So as Ioannis said, the National eHealth Interoperability Framework has been kicked off here in Greece in the beginning of 2020, initially funded for the design and implementation of it through the Digital Reform funds, which are available in all member states to leapfrog in the whatever reforms and transformation they want to achieve. So that was one major one. It's a program that's still running. It will end in September this year, and we are quite about at the end of it. We are at the projectathon phase, and we followed two main points. One was that we don't want to reinvent the wheel. The second is that we're going to follow the European guidelines and regulations and recommendations, which appointed the use of IHE profiles. So that's why the whole interoperability framework is based on reusing, wherever it's possible, IHE integration profiles and all the standards below that. We cannot speak about interoperability framework without having a very strong and robust governance structure. So one of the deliverables of the project was to deliver a proposal for governing interoperability with a national eHealth interoperability governance. And I think there is a similar approach in the Netherlands as well. And this is linked to the National eHealth Strategic Board, which is like a common board between the two main ministries, meaning the Ministry of Health and the Ministry of Digital Reforms. So in the project, we analyzed several use cases to see which one were more mature to be able to implement it. So those were just a list of those that we analyzed in the first phase of the project. We used a methodology that was proposed by IHE-Services. And based on that methodology, the group of people and experts, about 30 people, were discussing this issue in Greece. We decided about two use cases that were the most prominent to be developed and implemented smoothly and safely. And both of them were related to the laboratory results domain, both in the hospital domain and in the primary care. So the basic idea was to define, based on the existing systems in Greece, and propose additional common components that could fit to create this sense of an interoperability architecture, so that we reuse existing systems, but we can add new ones without changing the way things are being already created, because quite a lot of investment have been done in Greece in the last years. We skipped that part with Ioannis, but we do not really start from zero. So that's an overall architecture, which is quite a common one, with common components, with document repositories, with registries, with EID as a central component, terminologies, and all the other things that we usually do need to implement interoperability. The framework is based on the European Interoperability Framework. So the idea is to create a Greek one based on the European one. And the basic component was to create stable interoperability specification that can be sensed as national specification that will be used in all the tendering process that will come up in the future. And that's the basis of the work. Now, the specification in this project were considered as the cornerstone of the whole interoperability framework, because they influence the whole cycle between what we want to achieve, how this is going to be procured and implemented, how this is going to be developed and tested, of course, and this is a continuous cycle, which is the essence of the interoperability framework. Now, we managed quite shortly to organize the way that the specs will be organized under the National Interoperability Framework, and try to split them into three main groups: hospital components, cross-organizational clinical components, and national supervision components. And we have examples for the two first parts in the work that we did, creating documents that incorporate the technical frameworks of IHE where it's possible, with some additional Greek extensions where needed, especially in the terminology domain. In order to support all this, we obviously created a set of tools that will remain as our assets to the Greek Interoperability Framework to be continued in the next continuation of the project. So we used GitHub for the specifications, classical tools for creating them, and as well Gazelle as a testing platform. So we have organized now Gazelle to be able to test those two use cases. So that's more or less the schema with the actors and the transactions related to the primary care scenario, which is a bit more complex. And this is the same map of actors and transactions that are going to be needed to implement the lab results exchange within a hospital. So that can be added in the all the tender processes that Ioannis described in the Greece 2.0 program. Obviously, we had to conceive a testing strategy where the concept of testing prior to implementing is important. And the idea is that in July, between July 7 and 9, we will have our first Greek projectathon for those two use cases. And we already have about 22 systems registered and with 17 vendors. Most of them are from the Greek domain, but there are some of them that are international, like Oracle, for example. And we hope to have a successful testing event in a month's time now. This was a huge effort that happened in the last year, with quite a lot of meetings, with the working groups that have been created, with a lot of stakeholder meetings with the vendor associations and the expert groups. We organized training programs. And we had more than, we have now a vibrant ecosystem of 100 experts for both the vendor and the user community. And we managed to do, in a 5 months period when these specifications were finalized, we made more than 70 meetings and workshops, all of those online due to COVID. This is more or less the next steps in our plan. So we are getting close to the end of this phase, and obviously the continuation of the interoperability framework is included in the resilience fund. So there are funds to continue this work with new use cases for the next 4 or 5 years, and mature use cases as we go on, adding more resources and assets to the interoperability framework. So trying to close, this is where we are now. We are at the testing part. So we have a version of Gazelle, which is now hosted under the Ministry of Health. We have created all the needed material, and we have provided a first set of incentives for the participants. And the basic idea is to try to create an ecosystem of vendors that are compliant with the Interoperability Framework specifications that will obviously participate in the tendering process. And the idea is to co-create with those vendors those specifications so that there are no surprises during the tendering process and the implementation. And this is crucial since we have to do so many things in so less time. So 4 years, 5 years for these implementations is really a short time. So I think, Ioannis, that we managed to do this with 30 seconds delay. If there are no questions, Esther, I can give you the floor to continue.
Okay, good afternoon, everybody. First of all, thank you, Alexander and Ioannis, for this excellent presentation. It's really great to hear this ambitious project, and I look forward to hear more about it in the future. Yeah, I would like to introduce Evert, who is radiologist in the Netherlands, in the southwest of the Netherlands, at the Amphia hospital. And Evert will share some work he has been performing in IHE Netherlands, where he is user co-chair for many years already. And that's about a guideline on oncology consultation. So please, Evert, the floor is yours.
Thank you. Thank you, Esther. And now I'm screen sharing. Do you see my screen? Perhaps takes, does it work?
Not yet, but
why isn't okay? Okay, to do it another time. Okay, and now it should work.
Yeah.
Yeah. Okay. So Esther, you already introduced myself. Thank you for the opportunity. It's not my work. It's work from a lot of people. 2 groups I have to mention. That's the working group of the IHE Netherlands care processes. And the other group is NABON, that's the National Breast Cancer Consultation Netherlands group, and the National Cancer Registration. The subject that I want to talk about is about exchange of information because of tumor board meetings. In the past, tumor board meetings were organized in my own hospital, but today it's more and more regional, interregional, or national. It has to do with a lot of patients. The consultations, about 220,000 yearly in the Netherlands. It's a lot of different different types of information that has to be exchanged, and only imaging is part of it. But an academic hospital imports about 40,000 DVDs per year, and that's only radiology and nuclear medicine. Here you have an impression of the Netherlands with all kinds of well, hospitals and regional or interregional tumor board meetings. And here you have an impression of the tumor board meeting. It's not 3 or 4 persons, it's about 20 each board meeting. The problem is nicely illustrated in this image. The breast record, that's the topic we took for the moment. It's collected with care, but it's difficult to exchange and deliver in a proper way. And as a tumor board, you feel in a position as that monkey. So when there was the situation to update the breast record guidelines, people from NABON, the National Breast Cancer Consultation, as I explained, they decided not only to look at the written text, but also to think about interoperability of semantic interoperability, sorry. And just to have an impression about the problem, if you look to one breast cancer patient who starts with the general practitioner and ends in a tumor board meeting, in the meantime, we all together have written down 40 times right or left. So that's, if you consider that, it's not one thing that has to be written again and again. A lot of things we do double. This is the working group on semantic interoperability in the NABON guideline. They are officially representing the societies, medical oncologist, radiologist, surgical oncologist, pathologist, and clinical computer scientist. And well, it's always difficult with those kinds of lists. There are always people you don't mention. It's a lot of people who are involved. They described the information standard to how the information has to be exchanged. You start with initial diagnosis, initial treatment, and follow-up treatment, and the end situation, disease-free, chronic, or worse. You can also look at how the information in the timeline, where it comes from. Radiology has a special place, so you can make use cases about the radiology report, pathology report, and so on, surgery and the types of tumor, TNM classification and the corresponding care. You describe what kind of information has to land in the clinical information models, and then you have to exchange it collect it in an application. Now we have the information standard. How do we come together? That was new. And the problem was, how can we choose an approach that will work for each electronic healthcare record vendor instead of working with a content group for each electronic healthcare vendor? And the process of the guideline has to land in the application of the vendor. And so their process must be leading and not the vendor that is leading. And also on the user side, you have difficulties that are new. Some users put a lot of effort and don't have any advantages. They don't win time somewhere else, and others win a lot of time without doing anything. How can everybody get involved? So how to get this implemented in systems? Clinical people have no knowledge to translate their guidelines into technical specifications for the vendors, and also important, they have no resources, people, and money. In the meantime, the Ministry of Health take more direction on the electronic information exchange in healthcare, and they organized consultations for choosing priorities. That started in 2018, and that is where IHE Netherlands met the NABON people. And we, in 2018, IHE started with a working group on care processes. And they wanted to model complex healthcare processes with information and exchange standards. They were looking for multidisciplinary processes between multiple organizations, not only in between your organization. And they want to translate it in generic processes, so you can use it for later use in other for other use cases. And on the long term, they want to be a knowledge center for process and informatics professionals. They want to primarily focus on the supporting of healthcare professionals, the healthcare process. Multi-consultation is a nice starting point. Healthcare process is leading for the technical specs. And the outcome is not only focused on IHE profiles, so it's more the IHE process that we embraced using IHE profiles where possible, but well, just a little bit like in Greek, don't waste what there already is. Participants in are users like me, but also vendors. Enterprise architect of the Ministry of Health participated, and the chair of the, he's also chair of the chair of the working group was in a hiring role at the Ministry of Health. The working group was able to plot the guidelines on the cross-tumor board workflow profile. Well, some things are still in Dutch, but you can find here the layers of the interoperability model. So the NABON people, they in fact made the upper layers of the interop model, and we, the IHE working group, filled in the more lower layers of the interop model. And so here you find it's not only the filling in of the interop model, but also filling in the timeline. So you see the process information, request for multidisciplinary oncology consultation, and plan it, prepare it, perform it, finalize it. Well, they collected all the different kinds of information, and also they plotted what kind of application belong to that. We also looked at the standards that were possible in the Dutch situation. Well, we in the Netherlands we use DCM, so that's the summaries. We has organized that in detailed clinical models. So that's different. That's not an IHE profile, but it's the standard. And so this is the original situation in the beginning. At the end, we have written together with all those people. We call it IHE guideline, transmural breast cancer multi-consultation based on national and international standards, proven national and international standards. Those are the members of the working group, and there are two authors, Marlene Gigaas and Igor Schoonbrood. They were the main contributors. 1 year ago, we were able to hand this guideline officially over to the NABON people. So that was a nice event. This guide had an impact on the Ministry of Health. They asked to explain it another time, so we had a presentation there, and they now they consider to make it a VIP program, so an acceleration program officially funded by the government. Also, the healthcare insurance are interested. They already give a subsidy for in the middle of the Netherlands for a regional project. Healthcare professionals were also glad with the guide. They felt supported, so they can focus on their real job. They better understand the role of IHE. They also better understand the role towards the vendors, and they also realize the knowledge gap on interoperability. The southern region, Maastricht-Aken, they also consider it to use the guide, not for breast cancer, but for colon cancer. And they say it's more easy on that domain. The Ministry of Health, well, as I said, they had a program to prioritize. They selected 13 priority use cases out of 45, and they want to put it in a law. But there is no not one approach for use cases, and well, they had the idea to build a national interoperability based on more than one use case, but well, they have to realize now, in fact, you have to choose for one approach, and actually there is nothing besides IHE, in my opinion. And the working group is also working on now on a use case about lab results. There were some other questions. Guideline development is historically organized for the organization like NABON, but at the moment there is no organization who can govern, can organize the governance about the IT part of guidelines, and who will do version management, and what is the role of, for example, an IHE working group. It's filled with volunteers, and is there budget? Those kinds of questions raised. It's also concluding, procuring interoperability is not easy. It's not something like buying a new modality and ask for standards. Interoperability is simply not yet an effectively structured component of supply or demand parties, or between a link of the two. It's really working together. In contrast to many other industries, the purchasers of healthcare technology have not fully leveraged their individual or collecting power to require interoperability or by design. In other industries, that is more naturally organized. The interoperability by design is, for example, in airplane industry, well, essential, and in healthcare it should be essential. With better procurement practices supported by establishment of shared interoperability platform and architecture, healthcare systems can prepare themselves much more rapidly into the environment we want. You can read this in this paper from the National Academy of Medicine, a neutral organization. And that's the conclusion of my talk. And I have to thank all the people who have been working together with me on, well, this subject. Thanks. And Esther, can you take over?
Just a moment. Yes, thank you, Evert, for sharing.
I have to stop sharing.
Oh, it's okay. It can.
Walter, can you do it?
Doesn't harm if it stays. I didn't see any questions in the chat, but maybe someone would like to ask a question directly to you. You can just unmute yourself.
I don't know. I have the impression that in the Netherlands we are a little bit ahead in the regional and national organization of these multidisciplinary consultations. So, but for example, in Greece, I can imagine that a smaller hospital needs consultation from an academic center. So, is there any need in other countries to organize these consultations with groups of people outside the hospital? It's in fact.
What I can say, I don't know if Ioannis is still with us. There is, as part of the Greek project, there is one branch which is directed for the oncology domain. So restructuring and the tumor boards are part of it. So is this release or your document, it's only in Dutch or is it also in English? Can we reuse it probably to fine tune it in the Greek context?
Officially, we haven't translated in English, but I think somebody has.
Not yet.
Okay. So if there is, it's focused on the Netherlands, but well, you can use it. It's general. You can use it for other tumor parts, other tumor malignancies. You can use it in other countries. It's, well, you showed also something in Greece. What's there and what do we want? What's the use case? What do we want to reach? What kind of information do we want to travel? And make a map. What's already there that is usable and what's missing? Use IHE profiles. And in the end, it must be interoperable.
Can I add something? T here from the Netherlands too. What I see that more and more healthcare professional associations are aware that interoperability is part of their responsibility. We have another association, the clinic chemists. They developed a course for themselves on the domain of interoperability because they had to talk with vendors and they discovered we don't know what to ask. So they developed a course and they did it twice and it was so successful and it filled the gap that they want to offer this course to all their members. And I think this should be taken up internationally. And the second development in the Netherlands is that the National Healthcare Institute, it's about quality care and insurance. They are now adding an information paragraph to their quality standards. When a quality standards is covering a healthcare process, they are now demanding to the healthcare professionals to write down their policies, the processes and the actors and the information. And that's exactly what NABON already did. But now it will be demanded and it is based on the multi-level model of interoperability. So I think that movement is very important to get the users in a stronger position. And maybe Floor is also in the session. Maybe you can give your opinion on this.
Yeah, I think it's for me it's difficult because I'm very focused on the Netherlands, how it's organized in other countries. But like was presented in the former presentation, it's very important to include your care professionals in the first step of of reorganizing or doing your digital transformation. And for breast cancer, for example, it has started with the care professionals defining which information is crucial for breast cancer and which information is crucial to share between disciplines, and to design how the process should work in the ideal situation, which is very useful input for the technical, I call IHE technical people. Sorry, it's a little bit short cut, but yeah, so that helps. And I think that's very important also for the discussion, but also for the governance structure, that you both keep in contact, but that the medical professionals have a governance structure with the medical colleagues and also the IT people, and together they will speak with the vendors how it should be achieved. I don't know if that's the response you expected, TJ. Is that the answer you were looking for?
It's an important part that the others can hear what's your position as an important stakeholder. And yeah, we'd also talked, you want to get in the register at the Healthcare Institute with your quality standard. And there's now someone who has a new role of building the bridge between information and care, the healthcare. It's the old innovation manager, and we're going to talk with him because he wants to understand IHE and how can he use it within the Healthcare Institute, because he's now building the bridge. It will become national policy. And for now, when you are in the register with your quality standard, it has no implication on contracting, on financing. That will change in the coming years.
Well, thank you for these additions. I see one more post in the chat, posted by Ioannis, Kotsiopoulos. In practice, what is a shared interoperability platform? Good question. Who would like to give an answer?
In this case, it's a shared platform for the consultation, and that depends who are the members of the consultations. For example, breast cancer is always large amounts, so we do that local in the hospital, but for example, pancreas cancer, we have consultations together with the University Hospital of Rotterdam. So those kinds have to be part of the platform when there is a consultation. So the consultation has to, it must be able to create a consultation each time different. It's depending the kind of tumor board. So it's floating. That's in the past we thought, well, we have one vendor in our hospital, so now we have a platform. That situation doesn't exist anymore in the Netherlands, because we have a lot of different types of consultations with, well, different members, and they are working with a different vendor, electronic health record vendor, and they have to be able to see the information in their own environment. For example, the people who, radiation people, they consult normally 5 or 6 hospitals. They got crazy because they have to work with 5 different health record systems.
I see there's one more question, but we are a bit running out of time.
Yeah.
I guess we can spend just 1 minute on that question. It's posed by Floor. if in Greece there is, let me check. If there are registers for certain kinds of oncology, for example, for breast cancer, colorectal cancer, etc. Does Greece also has a national cancer registry, and is it included in the program?
Okay, thank you. I think this question is for me, perhaps. Yes, you understood pretty well. Greece will start a program on oncology. At this stage, we haven't really defined in detail which types of cancer will be included. We have set up different working teams here at the Ministry of Health, including clinicians, that will look into what is feasible for the next 4 years for the duration of this project. So I don't know whether they will focus on specific types of cancer as suggested, or whether it will be a broader program that doesn't have the specifics. My personal view would be that I would prefer if we start from specific types of cancer and then we expand. And the other question is, does Greece have a national cancer registry? The answer in a way is yes and no. So Greece had a national cancer registry that was developed a few years back. I think the design of it wasn't really intuitive, and not many healthcare professionals, were trained to enter the data directly. So they decided at some point that it will be a hybrid registry where people will have to fill in some details in paper and then send it to an organization that was looking after the cancer registry, and that didn't work. So in fact, the whole cancer registry thing, after a few years, also kind of stopped working. So we included a new type of cancer registry that is more aligned to what other European countries are doing. So we talked to Ireland and the UK about it. I don't know, Peter, whether somebody else contributed to this, but we looked into best practices around Europe to redesign the cancer registry, and this new cancer registry is part of this program now.
Okay, very interesting. I'm just asking because it would be nice to cooperate where we can, because I think Netherlands is also working on these, digitalization of oncology, specific breast cancer, colorectal cancer, and head and neck cancer. But for example, if Greece is working on other topics, we can better share than do it separately.
We would be delighted to do that. Actually, this is our mandate, to be able to work with as many European countries as possible on the cancer program.
Yeah, maybe we're already working together, and I don't know, because our organization has 300 people, but what would be good to connect? Is it via email, via this presentation?
Alexander, are you?
Yeah, I can organize with Esther the exchange of emails between the two teams.
No, okay.
Yes, and I think that's a great ending of this session, because that's part of what we envision to do, to connect all the good work together and all the people working at the same, to achieve better healthcare for everyone. So thanks again, all, especially the speakers, but also the audience, for your involvement in the discussions. And I'd like to close the session because I don't want to interrupt the rest of the program. Sorry, there's a plane here. So thanks again, and hope to see you in one of the other sessions later today.
Thank you very much. Bye-bye.
Thank you.